Um, and cool. And people will kind of tune in, and I'll try to mute them as they tune in. But we'll open up at the end for questions as well. But thank you very much for joining us. This is an honor, and I know you're are you in the travel club with both Nina and Gottschalk?
Yeah.
That's awesome. So
The
Yeah.
best travel club, but just
yeah, exactly.
Hopefully we're not the trauma club. We're like the
Hashtag hand club.
#hand club.
that's right. That's right.
Yeah, exactly. Well, anyways, for those of you who don't know Dr. Conti, she and I actually go back to when she was a hand fellow at Mayo, and well before she was the world famous hand surgeon that she is now. But she has risen up faster than almost anybody in the world at this point, and she's does really kind of cool novel stuff with education, with surgery, and leads one of the sort of premier hand fellowships in the country. So it's really our honor to have her visit with us to talk to her about how she kind of some things she's learned along her journey, and hopefully for the residents and fellows that listen to this, give you guys some insights into sort of what to do to sort of turn your own careers in the right direction. So thank you very much for joining us.
Yeah, thank you guys. It's a huge honor. I actually would say that you guys are like the fellowship right now. Every time one of our residents interviews with you guys, they come back like hot and bothered. They're like those Emory people, man. So I don't know what you guys are doing at your interviews, but I'd love to hear the secret sauce. I keep just getting pregnant and missing all of our interviews. So.
You make cute babies. You make cute babies, so it's okay.
Yeah, I'm done. We're done. We've done our share. But all right, I'm going to share my screen. So the fun thing about this topic, and I'm actually kind of excited that you picked it, was because it's more of a practice management, and I talk about a lot of this stuff with our fifth year residents and our hand fellows, because I think it's really important to discuss. I believe that one of the biggest failures we do as educators is we teach the technical part of medicine and not the art of medicine. So we teach all the black and white stuff, but we don't teach the gray. And the gray is actually where you practice medicine and you go from being a technician to a doctor. And that's where most of us live, is in that gray area of medicine. So hopefully this can be a good discussion. Feel free to unmute and speak up, ask questions, answer me with pearls, anything in your own practice that you think is relative to this conversation. So this should be a little bit more open of a conversation. So feel free to chime in. So my name is Mica, as Dr. Eigner just pointed out. I am at the University of Chicago. I am associate professor and an associate hand and upper extremity fellowship director with Jennifer Wolf. And I'm also a Simon Scholar, which is a position I hold looking at diversity, not necessarily just within my department, but also on a national level. So the goals of this is really just to start opening up your eyes, making you start thinking about what you're learning in a little bit of a different perspective. Because the first 5 years of your practice are hands down the hardest years. And hopefully you walk away from those 5 years a better surgeon, a better doctor, and even more beneficial, a better person. So I have zero disclosures besides the fact that I have lived my 5 years and they were hard, but I look back at them, and the things that I learned during those 5 years are like the foundation of my practice now. So the first thing I will say to you is evolve or die. A lot of times, once we get out of our education or our learning parts of our career, we kind of just always hang our hats on what we learned when we were a resident, when we learned when we were a fellow. But that doesn't necessarily always work, because eventually medicine's going to change. Your practice is going to be a different practice than where you learned. And even more so, you're going to find that you need to implement different techniques because of you as a surgeon and how you practice. So the best thing you can do is use your practice as constant feedback on how to get better. And I kind of use this algorithm of outcome of surgery equals the surgery itself or your skills, as my husband was joking and making fun of me when we were talking about this with a Z at the end. Patient selection and pre-op education. So all of these things combined together is what you get for your outcomes of surgery. And when you have an outcome that maybe you're not happy with, or you're really happy with, I usually sit back and I think, okay, well, could I change about the surgery? Or what did I do better this time that I had this result as opposed to another surgery? What was so great about this patient? Was this the right patient? Was this the right surgery for the patient? This is never where you blame patients. This has nothing to do with the patient being right or wrong. It's a matter of your selection of the patient, or the selection of the surgery, or the post-op protocol, et cetera. And the last thing was the patient's expectations set correctly. I firmly believe if you spend an hour talking about the surgery preoperatively, that saves you about 10 hours after surgery of explanations, setup, follow-ups, visits to the ER, et cetera. So I want to give you an example of this in my own practice of surgeries. Is I started seeing that I was having a lot of post-op neuritis, and I asked a lot of people, what they were doing and how they were taking care of post-op neuritis, and I kind of started to realize, like, maybe my incision was too big, maybe I'm lady handling the nerve too much. So I decided, okay, I'm going to try to be a little bit more minimally invasive and decrease my size of my incision, decrease my neurolysis to really minimal. And I found that I had a decrease in this neuritis. So the neuritis level is by these little lightning bolts. And I got a little greedy, and I said, well, what's better than good is, better. So I made even a smaller incision to the point that I was doing endoscopic cubital tunnel releases. And I loved endoscopic cubital tunnel releases. In fact, I've been doing endoscopic cubital tunnel releases for about 6 or 7 years. I've made videos on how to do endoscopic cubital tunnel releases. And I was like, well, how could I make endoscopic cubital tunnel releases even better? Well, I stopped doing blocks on these patients, and I just started using local, and that decreased the cost of them. And then I found out that the blade I was using was $700 a blade. And I was like, that's a little too expensive. So I changed systems to another system that was only about $200 a blade, but I could also use that for the same blade for my carpal tunnel releases. So that really saved money. And I was really proud of myself. And I said, look, I've perfected my cubital tunnels. Here I come, world. And then I cut an ulnar nerve. And let me tell you how bad that feels to cut someone's ulnar nerve. It's an awful, awful feeling. And I don't think that I look back at that time all the time. I even get a little choked up when I think about it, because it just breaks my heart. And I had to take a step back, and I realized, well, maybe I'm not being as safe as I think I am with the endoscopic, because clearly I made a big mistake. So I went back to open, and I made, again, a smaller incision, which is even cheaper than the endoscopic. And I'm not having as much as neuritis as I was having at the very beginning. I think my surgical skill and technique is better. I think I'm more thoughtful about it. But this is an evolution that I've gone through with cubital tunnel, and that's just one surgery. So not only the technique, the incision, the anesthesia, all of these things will change throughout your career. And these are things that you need to think about, and you also need to discuss with partners. So find mentors, find sponsors that you can talk to about these situations that you run into, and start figuring out how you're going to make the best of it and how you're going to make yourself a better surgeon every time. So the next thing is that patient selection. Patient selection is really, really important. And this is something Terry Light used to say to me, who is very, very knowledgeable. And for those who know him, he's just an amazing human being. And he always said, the first 10 years, you learn how to operate. The next 10 years, you learn when to operate. And the last 10 years, you learn when not to operate. And that is the biggest key to everything, is knowing when to use that scalpel and when not. Because the first surgery is the only surgery that's not necessary. Everyone after that is a necessary surgery. So think about that every time you are doing that primary surgery. Anything that red flags that like trigger in your head, I listen to them now. So every time there was a patient that I operated on that I turned to my nurse and I said, man, I really don't think I should operate on this patient. And I was completely right. And it was near to 2.5 years of almost weekly visits with him. And just nothing ever went right every time we worked together. And it was a very hard situation. And I had that inkling in the back of my head, okay, I shouldn't be operating this patient, but I ignored it because, you know, there was an x-ray that correlated with pain, but it didn't correlate with personality. And it also didn't correlate with expectations. And it didn't also correlate with similar outcome goals. Second opinions are a sign of a mature surgeon. Always ask for a second opinion. If a patient isn't buying into surgery, if they're not sure they want to have surgery, if they don't think it's the right surgery, any type of wavering, I always send them for a second opinion. And when patients come back from a second opinion, if they come back, that means that not only do they trust you, but they're ready for surgery. If they don't come back, then, you know, either you weren't the right surgeon for them, or they, you know, decide they didn't want to have surgery. But either way, that's a great outcome for both of you. If your patient doesn't want surgery, don't perform one. That is the minute you have to stronghold someone into surgery, even though you think it's urgent, not emergent, but urgent, don't do it because they're going to have bad outcomes. And lastly, postoperatively is when you learn the most about your patients. Everyone always says you marry your patients. It's really true. Patients, once you've operated on them, man, that like, it's like you've already had like, you know, that first or second date, and you start learning a little bit more about them. And sometimes, you know, you realize a lot of things about them that you didn't realize before, which is affecting outcomes and their postoperative protocol. So example of this is the procedure room. So I was doing surgeries in the OR, and, you know, that's obviously a cost. There's the staffing issues, and you're still in the OR because these patients, you know, take forever for turnover, et cetera, et cetera. So we fought really hard to get a procedure room, which is something I know that you guys are very interested in, and I am a huge fan of. Actually, my Thursday morning in the procedure room is my favorite day of the week. And bringing it to the procedure room was awesome. I mean, I have one MA that works with me every time, and I literally come in there in the morning before I even see the patient. She's already started setting up the room exactly how I like it because I work with her every Thursday, and she was specifically brought on to work in the procedure room. And then I can do about 7 or 8 surgeries in the time it takes me to do 2 or 3 in our ambulatory center. So I'm able to get a lot more done. It's at my pace. The patients are happy. They're really happy with the fact that they get to get their operations. They're awake. They don't have to deal with anesthesia. A lot of patients don't like the after effects of anesthesia. They can drive themselves there. They can drive themselves home. This helps a lot with patients who don't have family members. They can eat, they can drink, and also patients who have medical comorbidities that preclude them from being in an ambulatory center can have surgery done very easily in the procedure room with minimal complications or minimal risk. But I found that as I tried to bring all these people into the procedure room, I was realizing that there were some patients that were not enjoying the procedure room, and there was screaming and there was rustling. I mean, I've had to put sterile straitjackets on patients to keep them from moving. And that's when I realized, okay, patient selection has to be very specific. I may think that they would do wonderful in the procedure room, but that doesn't mean they think they're going to do wonderful in the procedure room. So any history of anxiety, any issues with like, you know, health issues that, you know, that could go awry, that they would be better with some light sedation, we go straight to the OR for those patients, and I'll do it under light sedation. I don't do it often. I've gotten really good at picking what patients should not be in the procedure room and which ones should, and I've been very successful. But I'll tell you, the first year or two, there were some patients that like, I just felt awful for them afterwards because they really just didn't tolerate being under local only. And don't tell Don Lalonde that, because he thinks every patient would do great in the procedure room. The South Side of Chicago doesn't agree with him on that. So The last thing is preoperative education. I love the example of carpal tunnel surgery because it's one of the most simple, hard surgeries we do. And so many people in at least my neighborhood believe that carpal tunnel surgery does not work. They say, my friend told me it didn't work. They had a bad outcome. Their pain didn't go away. And so I'm not going to get surgery. And the reality is the reason why that rumor is out there is because us as surgeons did not do our due diligence of educating our patients before surgery. So they had the correct expectations of carpal tunnel surgery because I'm sure it did work. It's just that they didn't get the results that they wanted. So you always have to remember the health literacy of your patient is around 6th grade. It could be a little bit younger. It could be even a little bit older than that. So things like the degree of your disease dictates outcome makes sense to you and me, but it may not understand it be that helpful to your patient. So things like the worse it gets, the less bang for your buck with surgery. Or other things I say, instead of outcomes are multifactorial with residual deficit considered permanent at 1 year, I just say your new normal is at 1 year. And they get it. And my patients come back and they're really happy with surgery. And I went from having to have a post-operative visit at 2 weeks, 6 weeks, 3 months, to I see them at 2 weeks and I say, come back if you have any questions, issues. And it's very rare that people come back. And if they do, it's because they actually have a true issue because they know what to expect. So it's really decreased cluttering my clinics, but it's also, you know, visits to the ER, phone calls to my nurse, all by just spending that a little extra time with education. So other career evolutions to think about, we kind of talked about the procedure room, but I didn't mention our anesthesia colleagues don't have really a great pain program quite yet. So they don't do post-op protocols, or sorry, post-op blocks. So sometimes those rescue blocks don't happen. So that pushed me to do things in the procedure room because I was finding that I was not able to do the blocks I needed. I've had patients canceled because they're too sick, but they were totally perfect for the procedure room. They did great. I haven't had access to the OR, but I need to get these patients done sooner than later. So, you know, I could just squeeze them into the procedure room without an issue. Another example is the metacarpal screw. I love the metacarpal screw. I literally do metacarpal screws. I teach them to my residents. They're doing them in like 5 minutes or less. And it's not about the OR time. I really truly think with, especially an educational system, you shouldn't be looking at the clock too closely. Obviously there are, you know, extremes, but by decreasing that OR time, I really decrease the cost of that screw. And also these patients are moving almost immediately. So they have less post-op stiffness and less occupational therapy. And the patients are getting back to work and to their life way quicker. I started doing endoscopic carpal tunnel releases. I only had one person ever in my training that did it. And he was a shoulder surgeon, so he didn't do it very often. But it's a really big niche here for me in Chicago because it's a very saturated market. So you need things that hold you out. But I do endoscopics under local only. So a lot of patients love that because especially people who like surgeons or people who use their hands a lot and need to go back to work immediately. This, you know, the incision's not in their hand. They're able to go back to work real quick. Complicated elbows. I love me some torture. Nobody else wanted to do it in the community. So they just started coming to me and I took it on. And now I really love working on the elbow. And I also do sports hand and wrist for our sports division. And that's because they needed someone. And I said, sure, I'll help you out with it. I never thought I'd be working on athletes. And I've had the honor of getting to work on some professional athletes and help them and get them back and win a couple championships. So that's pretty cool. My ring is still in the mail though. I'm still waiting on that. But these are all career evolutions that you just kind of have to look out for. And they just come in and you just kind of accept them as gifts as they come. All right, like I mentioned before, every surgery is necessary except for the first one. So surgery is hard. The problem with surgery is you're operating with really sharp utensils. So you're going to build a graveyard of cases that went awry and cases you're not proud of. And there's going to be patients who you did the surgery absolutely perfect and they have bad outcomes. And there's surgeries that maybe you weren't happy the way you had a purchase of a screw or whatever, and they have a great outcome. It's really hard to, you know, have replication of everything the same time every time. But bad outcomes do happen. And when they happen, and that could be, you know, the outcome of surgery, something with the patient, whatever, call risk management. And that's probably the best advice I've ever gotten. Not that I have a lot about bad outcomes. I feel like I had to say that after I've talked about it so much, but it does happen. And so the first thing you should always do is call risk management and let them know. If there's ever a situation with a patient, they have a lot of very sly and smooth ways of dealing with it. One of my colleagues had a patient that started to say a lot of inappropriate things, and risk management was able to manipulate the situation so that the patient wasn't going to see that physician anymore, but without it being known by the patient that they were getting maneuvered out of their clinic. Talk to someone, talk to mentors, talk to sponsors, see what, you should be doing in this situation, how to, recover. But the biggest thing is you need to talk to the patient as well. It's okay to apologize. These patients, you've now married them, so see them often and spend sufficient time with them. If you're having complications over and over again, like I was talking about before, explore why. And again, I can't say it again enough, is the power of the second opinion. So this is the most important thing I hope you gather from this, is that your job does not love you. I say this to all my workman comp patients, and you feel free to tell them too, because they complain about their job and how they don't do this for them and they don't do that for them. And I say, look, it doesn't matter. Your job doesn't love you. They don't. And that goes the same for us. These are our careers. We studied and worked our tushes off to get to where we are. And these careers mean so much to us. But the minute we're not able to work, we retire or we drop to the floor, they're already looking for someone to replace us. So I think it's important that you realize who does love you. And the biggest thing is to figure out how to make yourself happy. And surgery should make you happy. And when surgery's not making you happy anymore, you have to start worrying about burnout. And that's emotional exhaustion, depersonalization, low sense of personal accomplishment. And that's what we define burnout as. But that's happening a lot with orthopedic surgeons. I mean, those are some of the WLA articles we've been having to read in the last few years, is about burnout, especially with COVID. It's been really, really prevalent. There's a couple of studies, one that showed us that we tied with the OB-GYN physicians for the 12th happiest specialty. And I don't know if you've met any OB-GYNs, but man, they have it rough. So I was really shocked when we tied them for happiest specialties. We have a high divorce rate of 30%. General surgery is 33. I thought we definitely would have had lower, way lower than the general surgery, but psychiatry is pretty high at 50%. So, that's still something that you need to be aware of when you're looking at your long-term goals of not your career, but your life. And then also we have a really high suicide rate, which shocked me when I found this out. They looked at suicides with physicians from 2003 to 2017, and this is specifically surgeon suicides. 28% of those surgeon suicides were orthopedic surgeons. So obviously if you need help, definitely look for it, but try to get to keep yourself this all in check before it gets to the point where we're starting looking at extreme situations. So how do you find that work-life balance? Well, the biggest thing is you need to start making a plan. And I think we all have gone through our training of saying, okay, in 4 years, I graduate medical school. In 5 years, I graduate from residency. In 1 year, I graduate from fellowship, and maybe you'll do a second fellowship, so another year. And then all of a sudden you're in practice and there's no next thing. It's not like, okay, I work here for 8 years and then I'm going to switch to this place for 8 years. It's just at that point, now you're in practice. So you have to create your own goals and your own plan. And a lot of times, especially in business, they make a mission statement. And I would actually encourage you to do it. I thought it was really hokey when I heard it the first time, but it really helps you kind of figure out what you want to do with your career and with your life, and then create a timeline for that, making both personal and professional goals. So to give you an example, what's important to me, this is my husband, Mike. We have been together for almost a decade now. And we have 3 kids who are awesome. And I've made a huge part of my career to be there for not only my husband, but for my kids, which has made a lot of different sacrifices that I've had to make in my career that I never thought. So I decreased my hours. I don't work on Fridays anymore. And Friday's Mama Day. And I am with my girls. I turn my phone off. The only person who can contact me is my nurse. Granted, sometimes I'll answer for the residents, and the fellows, but Basically, the nurse is really the only person that's supposed to contact me just in case there's any patient issues, unless I'm on call, and then I'll put my phone on again. That was something that was really important to me. My husband and I have moved our schedules around, so we're always picking up our daughters and dropping them off at preschool. And we also have to have a full-time nanny just because my husband's also a surgeon. So, you know, that's a lot of work on our part, but we've done everything we can to try to give as normal of a life for our kids. And when I graduated from residence or from fellowship, I realized I hadn't read a book for pleasure in almost 6 years, and I love reading. So I joined a book club when I graduated from fellowship, and I've been with that book club, and not one of them is a surgeon or a physician. And I read with them, and totally different crew of people, and we read at least 1 or 2 books a month together. And it's been one of the most amazing, like, little gifts that I've pushed myself to have. I travel. We at least try to do 1 international trip a year. We just went to Portugal, and next week we'll be in Israel. Skiing, scuba diving, all things that are really important to me. Baking with my family, with my daughters, teaching them how to make challah and bablicka and everything else that we make in our family. And I also like to be active. So I made those as important things for me to counterbalance my career, so that when I went to my job, I would be happier. And it took me a really long time to give up my Fridays to be with my girls. It sounds like a no-brainer, right? You're like, oh, sweet, you work 4 days instead of 5. That sounds awesome. But there's a lot of anxiety about that on your part of giving up a piece of your career. You're like, is this going to hold me back? Am I going to, you know, and then once you give that all away and you're like, wait, what am I gaining? I'm going to be with my family. I actually have more RVUs with a 4-day work schedule than I do with a 5-day work schedule, because I was so burned out. So that, you know, I see these articles about the 4-day versus 5-day work week, and I laugh because I would have been like, go to work, you know, and now I'm like, oh wait, it's actually true. I am more productive now with a 4-day work week than I was with a 5-day work week, because I'm not burned out. So I challenge each of you to make a 1-year, a 5-year, and 10-year personal and professional goals. See how your goals coincide to your significant other. So I would definitely do them separate and then bring them together. It's really important to do this, because, man, what's going to happen in a couple of years if you guys go off to this different path? It's really going to be hard to get back in there. So you guys need to make sure you guys are on the same path together, and make new family goals. I mean, man, my life, you know, 5 years ago is different than the life I have now. And what's important to me now is completely different than it was 5 years ago. So I would really push you guys to make these goals and to keep readjusting them, because as you evolve, you got to remember your job doesn't evolve, only you evolve. So you have to change your job to evolve with you. Okay, the tale, I'm keeping an eye on time. A tale of 2 ships, mentorship and sponsorship. This is America's Cup. I don't know if anyone's sailors here, but they finally had it here in Chicago, and then there was like no wind. It was like so pathetic. But very fun race if you ever get to see it. So mentorship, I'm not going to talk a little bit that much about mentorship, because I feel like we've really beaten mentorship and sponsorship down into people's head. But the biggest thing that I always had to realize with mentorship is that it's critical that you have this mentorship, because it's directly correlated to these things, which I didn't realize: retention, job satisfaction, clinical volume, networking, progression, productivity, promotion. But the thing that's important about mentorship is you really have to seek it out. It's not like these people who are super busy and super important are going to be like, oh, I'm going to give up some more time for you. They are going to have to invest in you, and you're going to be the one that has to make them want to invest in you. So it is mutual, but you really are going to have to seek it out. But with sponsorship, the biggest difference is that you don't always know who the sponsor is, but they're advocating for you. So they're putting their name on the line for you, which is a little bit different than mentorship, because they're just telling you and advising you. But with sponsorship, they're putting a little sweat into the game. And this is really more powerful, because this will jumpstart your career, provide opportunities, is super influential. And there's a risk for the sponsor. So you really have to be invested into making sure that that sponsor is rewarded with you doing well. And again, you don't always know who your sponsor are. We actually had a conversation with this in my hand club about some of the things that we've happened to us, and like we didn't know who was the sponsor. And then finding out who that person was like years later, it's kind of mind blowing, because some of these times you've met this person once or twice, and for whatever reason, you guys, you know, hit it off, and then they thought of you for this position or this job, and you had no idea. So I always thought mentorship and sponsor was this, like there's a mentor and a mentee, and you meet, and that's kind of that person you go to for everything. But really what you want is a network. And this is where I found in my first 5 years is what I had to build. And it's really important to be successful is building a network. And the reason why the network is important is everyone is good at being a mentor or a sponsor for a different thing. So there's somebody who's really good for me as a research mentor, and I call them about research stuff. Well, when it comes to, you know, life stuff, man, there's gonna be a lot less people who are gonna be help me discuss, like, you know, pumping and whatever else I need to talk about. So my life mentor is gonna be a little bit different. And then I found that I started getting some great mentorship from some of the senior hospital faculty, some ENTs, the clinical dean of the medical school, and all these people that I didn't really know who they were, but started talking to them in the surgeon's lounge or like leadership things or other types of meetings. And I started being like, wow, you guys are really helpful. And then all of a sudden I ended up on all these other leadership stuff because of that relationship. And they helped me, you know, navigate some sticky situations that I needed help from. And I needed an opinion from someone that wasn't part of the situation. You know, you obviously have your department head, your co-fellows, man, I'm really close with my co-fellows. Two of them specifically, Paige Fox and Heather Balzer. Hopefully I'm going to see Heather next week in Israel, and Paige and I are doing the ASSH annual meeting in Toronto this year together. So, which you guys all should go to. But these are all very important people. And this is how you get a balanced mentorship sponsorship situation. So, a lot of people do this, and I would tell you, you're going to lose out, because someone who's a really good mentor at research is not going to be really good for, you know, whatever types of surgeries you do. So make sure that you really, really create yourself a healthy web to fall on when you need it. The bottom line, we all think that, you know, if we're good surgeons, we put our heads down, we're going to be rewarded. The hospital cares about a few things, and one of the big things is that dollar bill. So the bottom line, and I think this is really important to understand, because this is how you figure out your bonuses. This is how you figure out if you're busy enough. This is how you can figure out if you need a PA or a mid-level. This is how you figure out numbers so that you can go talk to your clinic people and say, look, I need more rooms. I need to have this day instead of this day. I need to start at this time and not this time. Because if you give them data, people can't argue with numbers. They can argue with personalities. They can argue with people, but they can't argue with numbers. So I had a really smart partner who doesn't work with me anymore, but he sat down and he started teaching me all this stuff on. I was just sitting there. I was like, wow, this is so fascinating. So I spent a lot of time trying to figure this out, because I wanted to start hitting bonuses, and I didn't like know until I got till, you know, the end of the year if I was going to get that bonus or not. And I started realizing how to make those bonuses or how to hit those numbers. So I got up to the next spot, which could then mean, well, maybe I can get better, you know, clinic times, better OR times. Maybe I can have a little bit more weight around the room because I was a high producer. So the biggest thing is knowing the number of RVUs you average per clinic. And that's just the number of new patients times the RVU. So like 1, and then returns, which is like a 0.9-ish. And then that gives you your total. So you kind of have an idea every clinic, how many RVUs you're making. And then clinic utilization. So the number of spots divided by, and filled spots that are there times 100 gives you a utilization number. This is really important when you're trying to get more space. You'll actually find that your no-show rate goes down as you become more senior, as people have more of a weight. Then people are like, I can't miss it. I waited a month and a half for this. But if like they made your appointment like 2 days ago, they're like, man, like, you know, I made it 2 days ago. I probably could make another one. So you'll see that as you get higher in demand, that no-show rate goes down. But that's really important for getting more clinic space, is this clinical utilization and no-show rate. And the last thing is your hit rate. How many patients do you need to see before you sign someone up for surgery? And that's the number of patients divided by the number of surgeries, and you'll know your hit rate. And that makes an idea of your thing. Okay, I need to do 20 surgeries this week or this month or whatever to get my bonus, then you're like, okay, well, I only have 14 scheduled, then I'm not on the right track. I need to open up another clinic so I can get those numbers. So by hitting those goals, you just need to set a monthly goal of how many RVUs you want, and you just subtract your known number, which is your clinic number of patients. And like we talked about before, the RVU average, and then divide by the average revenue per surgery. So the number of RVUs, and this will be the cases that you need to perform per month. And then compare the number of cases you perform per month, you need to perform by your hit rate and see if they're the same. So basically your goal RVU minus your clinical average RVU equals the RVUs you need to make by surgery. So you take those surgery RVUs you need to make by the average surgery, average amount of surgeries, RVUs you make for surgery, which is a lot harder to do in hand, but easier if you're like in joints. That will give you a number of cases you need. And then you compare that number of cases to your hit rate and see if you're seeing enough patients. I hope that kind of makes sense. I went through that very quickly, but if you take screenshots of that, that may help you to start thinking about that. And understand the book. So when you're signing up for a job, a couple little things, this is for the fellows, your overhead should be less than 50%. So look at the overhead and understand why the overhead is over 50%, because you're gonna be paying a lot of money to just put your shingle up. Leakage, you want this to be low. Obviously, these are the patients that you lose out of your group. You want this to be like either through like therapy or other surgeons for second opinions, like too long of a wait, etc. You want these patients to always stay closely within your community. Collections versus charging, you want this to be over 30%. So basically making sure your billing is up to snuff and that your contracts are reasonable. And then understand what makes you a partner and see if it's reasonable. I think a lot of people go out and say, oh, I want to make a ton of money. Whatever money you are given to by a practice, they expect you to make it back. So make sure that you have a reasonable salary that you think you can make, because then you don't become partner until you're agreed. And then you also need to understand what you get for being a partner. So some places it's great. Sometimes there's like this hierarchy system of being partner, and some people never get the option of being partner. If you're in a hospitalist position, for me in academia, there's no partner. Some of these things don't really apply to me, but my husband is in private practice, and I feel like in academia we don't talk about this a lot, but this is really important. And I will tell you, my husband gets called by all of our residents and fellows to help them go over the contracts and to go over the books with them, so that they understand they're making a really important decision, or making the right decision. So that's something I would tell all of you guys to think about. The art of saying no. I think we're always told you got to don't say no in the first 5 years of practice. And I think there's something really valuable about that, because as you saw at the beginning of the evolutions of my practice, a lot of that came from saying yes to things I wasn't sure I really wanted to say yes to. And then it turned into something really beautiful. But there are and understanding if you are going to say no, what those consequences are. I did say no to this one guy who was always dumping on me with patients, and like I would say probably 30% of the time there were patients I actually wanted, but he was a senior person in the community, and I just really didn't want to upset him. But one day he sent me a patient that like I actually could not help. Like I did not have the skill set to help this patient. I knew somebody who could have done it. So I said, no, let me introduce you to the right person. And I set up him with this person. And so instead of it sounding, no, I can't do it, I said, you know what, I have a better person for you. And it made me sound like I was helping him without actually having to do anything. So the art of saying no, but making it sound like you're saying yes is really important. Because if you're going to say no, you need to understand what the opportunity is. If the opportunity is going to give you something that's important to you, say money, promotion, personal fulfillment, that's worth saying yes to. And that's the question you ask yourself. Is this worth the time I'll lose being with X? And for me, it's my family. And if it's worth me losing time with my family that I can imagine, saying to my family I have to leave because of this, then I will say yes to it. If I say no to it, I don't say necessarily no. I say it more of like, I'm saying, yes, it's a great thing. I have the perfect person. Let me connect you to them. Or I'll take on that case for you. Why don't you send it to me? And then you send it to the right person. And explain why you're doing what you're doing so that people understand that you're not just like insulting them, but instead it's because X, Y, and Z. I turned down some really big leadership opportunities that probably could have taken me really far, but I didn't think they were the right situations for me. And while somebody was really excited to offer me these opportunities, I can only imagine how insulting it sounded when I said no, but I let them know why. And one of the reasons why was because I didn't think I could do a good job at it. And I didn't want to take on something that I was going to fail at. And I knew that there was a better fit with somebody else. And that turned out to be real. And those other people who are doing those jobs are doing a way better job than I could have ever done. So what I talked about before is show me the data. Let's talk about this a little bit in a different kind of realm. So show me the data is important when you're in clinic, when you're trying to get things, but it's also important for conflict resolution. Always have data like names, dates, times to back you up. Utilization. I had one of the new attendings when I was a 5th year, never negotiated block time. And so he was doing cases at like 12 o'clock at night that were like elective surgeries. He was a tumor guy. So he was doing like hemipelvectomies at like 2 a.m. It was ridiculous. And he finally came to the head of the department. He's like, look, my wife's about to like divorce me. I have to change something in my practice. Here are all the cases I've done in the last 5 months. And this shows you the utilization of time would be more than 1 day of utilization in the OR. And here are, all of these ORs that are not being utilized to the 80%, which is what the hospital asks you to use, is your utilization should be at least 80%. And they gave him block time. But if he came to him and said, I want block time, my wife is going to leave me, I'm really unhappy, that just doesn't come off correctly. But when you give them numbers and you say, hey, I'm filling up an OR and I got to do it at the right time, like this is unsafe for patients, it's going to come off completely different. So come with a solution. No one likes complainers. And you also have to be okay with your solution not being the one they choose. One of the best things I ever did is I did Second City. And I don't know if any of you guys know Second City, but it's an improv. I graduated their improv program. And the reason I took it was actually for public speaking, but it helped me in life because one of the things that they do in improv is that concept of yes and the only way things work in improv is if you take someone's suggestion or whatever they say to you and you have to build on it, because if you say no or but, you've ruined the scene and everyone's kind of falls out of it and doesn't understand what's going on in the scene anymore. And that's kind of how it works with conflict resolution. When somebody suggests an idea for you, build off of it. And you might find that while it might not be the number one solution that you were thinking of, you may have actually found a mutual understanding between the two of you and you both win, which means that you're going to have a better outcome than one person winning. Pick your battles. Look for patterns and unless it's a never event, then you don't want to have never events to be a pattern. And then talk one-on-one with simple mistakes. So if you have an issue with somebody, don't go to your senior person, go talk to them. The worst thing that can ever happen is that your senior partner comes up to you and says, so-and-so said this, and then you never heard about it. And you're like, why didn't they talk to me about it? And that's a great conflict resolution thing you should know. Never respond emotionally. Whenever you're really upset about something, take time. And anything that you do, don't do it in a way that can be documented. So if you have, you're frustrated and there's a situation, call so that there's no emails that can be forwarded or misconstrued. This is something I learned from AOA. And this is my last slide, but this is about problem solving. So this is what everybody wants. This is you want to have this outcome. This is meaning you get everything you want. Well, the other person is going to want everything they want. And if you don't compromise, you guys are both going to lose. And this is where you're going to end up. But if you compromise and you guys do a yes and situation, you generally end up here, which means you've maximized how much you're getting from the situation and they're getting from the situation. So you start working together and maximizing instead of trying to fight people. So I think this is really important whenever you're thinking about it and you're thinking about the things that are really important to you. Think about all the things that are not important to you and you have no problem giving up, but don't show those cards. When people ask you for those things you don't care about, act like they're getting a chance to win in that scenario so that they feel comfortable to give you and you guys build off of each other. So those are kind of some, just a quick run through of things that I learned in my 5 years. There's a ton more, but I just want to start strumming up some thoughts in you so that when you're in clinic, especially the fellows and residents, that you start asking questions of not like, what are the indications, but why did you choose this surgery instead of that surgery? Well, why did you start doing this surgery? Why do you use this plate instead of that plate? And like, how did you deal with that difficult patient? Why do they love you so much? Like, how do you deal with this type of personality? Those types of things. Like, how did you build the schedule you're building? What's your template in clinic? You know, those types of things that I had no idea. Like, why do you use this kind of splint? What about this kind of splint? What's your relationship with your therapist? How do you, you know, those things that actually matter in that gray area of medicine that makes us an artist and make us like practitioners instead of technicians. So thank you for your time. This is my email if you ever have any questions. If you have questions now, I'd more than love to discuss this further.
I do have a question, but completely unrelated to this, but I'll do it once we stop recording. I have, not because of that. I want you to actually, I want you to review a case and tell me what you would do.
Okay, you learned something. Don't ever leave anything where people can, take note of this, right? Because this is being a recorded video and now everybody knows.
It's just because, yeah, it's just because it's got PHI. That's the only reason. I've got the X-ray or CT pulled up, but it's always a very enlightening talk. I mean, so many different pearls. I mean, like so many of it rings true. It's like I remember seeing like a distal radius and be like, oh my God, they have to have surgery. They absolutely have to have surgery. And they're like, I don't want surgery. I'm like, no, you have to have surgery. Like your wrist is like so far displaced, and like I really don't want surgery. And then somehow you end up talking them into operating, and it's like, oh, they get an infection. Like, see, I told you, like if I wouldn't have had surgery, it wouldn't have gotten infected. I'm like, yeah, but your wrist was like off in another stratosphere,
Yeah.
But sometimes I think you learn your lesson. And you say, okay, and you just, everyone's like, well, what do you do? It's like, well, you just document it. You're like, I recommended surgery, but you refused,
Yeah. And you know what? They're probably more happy not having surgery with their.
It is surprising, the mind really goes to like, it's surprising you do it. And you're like, look how good I am. And the wrist barely moves, but they're like super happy. You're like, okay.
Yeah. That's why you don't treat x-rays, right? You treat people.
Yeah.
Hey Spencer. So this Megan, this is Spencer Chambers. He's one of our fellows. Unfortunately, the other fellow is in France right now, so she is not on. But
Wow, look at you guys sending your fellows to France. What is this?
It's by choice, so it's not that unfortunate, but
so Spencer is going up to Hulk up in London next year.
Oh, good
So
for
Spencer,
you.
do you have anything you want to chat with Dr. Conti Mica about?
this is going to be a hard question to answer, and I think a lot of the gray stuff really is. I find a lot of times in life I realize what I should have done after it's already happened. Like, I think that's kind of the nature of it, and you touched on that quite a bit throughout your talk. And then I also find after I did something, I figured out how I should have done it. Do you have any advice or resources or ways to expedite that learning curve, or it's kind of just got to go through it?
I think it's a lot of it is communication of having people that you show cases to and you discuss outcomes with. It's a lot of an ego check, I think, is the biggest thing, is because when things go awry, you almost don't want to talk about it. You're embarrassed about it. You're frustrated. You get defensive about it. But the best thing you can do is call people like, hey, have you ran into this situation? Like, what have you done? Or, I call my senior partner a lot about things that, like, sometimes I'm like, I can just look this up in a book, but I don't want the book answer. I want the, like, what are you doing in the 15 more years of practice you've had over me answer. And I'll have people that I talk to just about elbow. There's people I talk about, like more practice management things, and you just building that mentorship, sponsorship network. And the more you communicate, the easier it becomes. But then you also start hearing things that other people's cases are and things that they're running into that you didn't even know was an issue yet. And then all of a sudden you run into it and you know how to fix it because of that communication, you know, of listening and always trying to learn, you know, attending these types of conferences, going to your annual meetings, all those places are great places to learn, and try to like just keep pushing yourself to forever like evolve.
And then some related question to your talk. I find some of the best and worst parts of clinic or everything else is kind of dictated not by you, and that could be somewhat of a frustrating thing. Any advice for kind of getting everyone on the same team? And what I mean by that is sometimes you go in and you know that there's going to be a scrub tech or scrub nurse that doesn't show up, doesn't pay attention, and that ultimately kind of falls to you. Any advice on making that more congruent? Because the opposite is also true when you've got a great team, everything seems to be easy, and you touched on that for your Thursday days, is a lot of the medical assist makes the day run.
Yeah, so it's funny. One of the things that I really identified with our institution is, so I'm RVU based. So the more surgeries I do, the more money I make. Whereas with anesthesia, they are salaried and they work 12-hour shifts. So it doesn't matter if I finish early or if I finish late, they're leaving at 5 o'clock. Our nurses are union, so they live by a whole different set of rules. And then you have all three of us trying to get through the same day with different goals, with different expectations, and you know, different passion. And that's really, really hard. So you have to figure out how to make everybody do their job while also like making it an enjoyable place to be. So not hounding anesthesia, but maybe communicate beforehand, be like, these are my goals for today. These are what I was thinking about for anesthesia. What are your thoughts? Engage them into it so that maybe they'll buy in. They like actually want to be in your room. And then, you know, you start working with some of the anesthesiologists that like are engaged because they want to be with you. Same with the nursing staff of like, hey, let them choose the music, you know, like at least if they're not going to be engaged, they have the music that they enjoy and they're not going to be grumpy. You know, you got to look for those little wins. The procedure room came out of the fact that I was doing these cases in the OR and I wasn't using anesthesia, and the anesthesia attendings were getting mad because they didn't, you know, there's rooms that they didn't need to fill. And so then they weren't showing that they had the need for more anesthesiologists when in reality they were shorthanded. So they pushed with me to get us out of the OR into the procedure room. So we had two different reasons why, but with the same mutual outcome of getting me out of there so that I could do my cases without dealing with a lot of the issues I was having in the OR. And they got me out of the OR, and then they could have anesthesiologists get their numbers that they needed to hire new people. So I think you have to kind of sit back sometimes and figure out what's going on, and figure out, going back to this slide of what you want and what they want, and seeing how you can come here. But if you are like miserable to them, you're going to end up here.
Thank you.
Can I ask a kind of follow up on the procedure room? I have to ask. So I do endoscopic carpal tunnel as well, but I've been I do them with blocks so patients can sort of watch them. And so I keep patients awake for most of them, but they like. The reason I do blocks is because I do use a tourniquet. When you do your Roulant, I assume you don't use tourniquet, and you're able to do the endoscopic. Because I used to, when I was doing open, I would do Roulant and could easily keep it up. But I kind of worried / was wondering if you inject all that fluid and fluid into the carpal tunnel, it would make the endoscopic harder. Can you maybe give me some technical pearls on if I wanted to do Roulants,
I will tell you, there's a video and there's a paper technique on it that I can send you. I will tell you, for me, it was a huge evolution because it's so easy now, Eric. It is like the best because I do it in the procedure room, and I got a tower that they were throwing away because it was an old sports tower that couldn't take pictures anymore. And I said, fine, I don't need pictures. And so I got an old tower for free. I got the scopes that go with that tower because they were getting rid of all of it for free. And then I have my own trays that are in the procedure room, and the only cost really is the actual blades. But we can talk about it further, but I do all of my injections in a ante room.
Yeah.
And then they wait until I'm done with the surgery. So I do a surgery and then they come in, and it's so important to do it that way, because as surgeons, we're so impatient. We're like, okay, it's been 10 minutes. You're totally fine. You can't feel this right here, but you really haven't waited the 20 to 30 minutes you really need to wait for it to set up. And that's where I think we fail. So that's why, for me, I never do endoscopic first. I always will do the trigger finger, my first case in the procedure room, because that doesn't need very long to set up. So I can give that 10 minutes, boom, I can get started. But while that trigger finger, I'm doing that surgery, the endoscopic can be numbing up, because you need a little bit longer for that nerve to get numbed up. And I do it 2 injections, so 20 cc's total, the same combo of 9 cc's of Lido with epi and 1 cc of sodium bicarb. And I do 1 injection where I do a wheel right here, just proximal to the wrist crease, just ulnar to the palmaris longus. And I do a little wheel here of a couple cc's, and then I go deep and make sure that you don't see a wheel, because then you'll be deep to I know I'm deep to the fascia and there's no resistance. So I know I'm not in the nerve, and they'll tell you if you're in the nerve. And I put the other like 7 or 8 cc's there. And then with the second one, I start here and I go and I inject all the way distal to the transverse carpal ligament. So the transverse carpal ligament's right here. I've gone over the top of it, and now I've shot it underneath too with that first injection. So circumferentially, I've injected around the transverse carpal ligament, getting all of the nerve endings. And then, because everything's numb, if there's water, if there's still some fluid in there, which I know there's a couple of papers that say you can't do it because of the fluid. I literally take a Raytech and I use a pickup, and I just drain out all that fluid, and I can see perfectly, and there's no bleeding, and it's super easy. And it's because it's this great niche to do, Eric. They would love it. I have people who fly from other states to get it done there. It's wild, because like they're pregnant or they don't want to deal with anesthesia. This is what they want, and they want that endoscopic open, or endoscopic as opposed to open, and they'll come to see you because they need people. But I can see that paper. There's a video.
Yeah, if you don't mind, that's awesome. Because I without question, I agree that endoscopic people love, and they also love watching the surgery, because I put up a little
on the screen.
I put it up on the screen, let them watch it, and they're like, "Well, what about surgery?" But like I said, I've always done it on blocks because I use tourniquets. So I would love if you don't mind saying me something.
Yeah, I'll send it to you. I would say that when you first start, I would do it with no tourniquet. I would do the injection. I would give them a little bit of max sedation. Just a little bit, just as you get comfortable. It's more for you than for them, just so you feel comfortable. And then I would switch to, doing it. And that's how I had done my evolution, is I did it because they taught you when you do it to do LMA. So when I first started doing it, I did LMA, and then I went to MAC, and then I went to local only. So, you may find that you do 1 or 2 under the MAC and you're done.
Yeah. Cool.
Hi, Dr. Conti. Mica, can I ask a question?
Yeah, please.
I'm a 3rd-year resident at Emory. Thanks so much for your time.
Yeah, Megan, Z's coming to us from Brazil right now. He's at a conference, presenting at a conference in Brazil.
What?
So.
Man, you're dedicated. You should be out like having a drink right now.
Because the Caparinos.
He's like, I
know. Thank you for your time. No, I really enjoyed your concept of the mentorship sponsorship network. I was thinking, do you your mentors and actually telling, asking them to be your mentor and regularly meeting up with them, or do you develop this mentorship model spontaneously?
It's both. I told Steve Moran one day, I said, "You are my mentor." And he said, "Okay." And so, he meets for me from time to time, not on a scheduled thing, but Jennifer Wolf is, Jennifer Wolf is my first female mentor sponsor I ever had. I never worked with a female surgeon or had one as a mentor. So when I started working with her, which was in practice, my 2nd year of practice is when she joined UFC, we started meeting on a scheduled basis. So we met quarterly. We don't meet that often now, but we did. And I really needed that at the time. But your relationship should be able to change as your needs of each other change. And it's really you got to remember, sponsorship and mentorship is usually like pretty unilateral, like it's going all towards you. And so you have to be really respectful of their time, because usually the people that are helping you are really, really busy people. But at the same time, like they find such joy in helping you that they want to see you succeed. So you kind of have to find what works best for you and that person. And that's the beauty of having a network, is that there's no formula to it. It's not like you have to do it one way or another. It can be based off of your relationship type or personality. A lot of research I've seen with research mentors that generally is more regulated, because obviously you need to make sure that research is propagating. And so that's usually one of those ones I see people in their meeting on like a quarterly basis, but it's all different.
Thank you.
All right, thank
Anybody
you guys.
else have any questions?
It's been great.
Awesome. Well, thank
No,
you
I
very
just
much for
wanna
joining.
showcase-
Yeah, I'm gonna